Hello, everyone. My name is Bill McAvoy, and it's a pleasure for me to introduce today this WHF webinar entitled Preventing Cardiovascular Events in Those at Highest Risk, Closing the Policy and Implementation Gap in Secondary Prevention. We have three great speakers today that we will introduce shortly. But before I do so, I'd like to introduce myself. I'm a professor of preventive cardiology at the University of Galway in Ireland. I'm also the director of the National Institute for Prevention and Cardiovascular Health, and I'm the co-investigator, or the co-PI, I should say, for the InterAspire study, which we'll briefly introduce during the background for this webinar. By way of background, we know that about 35 million people have an acute coronary or cardiovascular event every year, and about 1/3 of those occur in individuals who have already had a known cardiovascular disease. So these are patients who are what we would call secondary prevention patients. So there exists a strong evidence-based guidelines for the provision of secondary prevention care, but despite this, there's an alarming care gap, and many patients are not receiving adequate care. This webinar will explore global, regional, and national level policies that are working to overcome these challenges to optimize secondary prevention care. And we hope to inspire attendees to help close the policy and implementation gap in secondary prevention. There is significant momentum around the world on this topic. At the global level, the World Heart Federation is about to launch the update of its roadmap for secondary prevention of cardiovascular disease, and we'll hear about that in a moment. This will set a conceptual framework for policymakers, healthcare system, and healthcare professionals to address barriers in implementation of secondary prevention. At the level of the World Heart Organization, the Global NCD Compact 2020 to 2030 aims to accelerate progress in prevention and control of NCDs with the target of preventing 50 million premature deaths by 2030. As co-PI for the InterAspire study, we know and have just presented at the European Society of Cardiology that there is a significant implementation gap in secondary prevention around the world. We studied approximately 4,500 participants in 14 countries around the world, and less than half were taking the 4 drug pillars of secondary prevention, and only 1% were achieving all lifestyle and risk factor targets 1 year after their index presentation with cardiovascular disease. There's also unprecedented momentum for change in CVD policy in Europe, and the European Council presidency trio, Spain, Belgium, and Hungary, have officially included CVD in their program for the next 18 months. Also in Europe, a coordinated effort has been made by the European Alliance for Cardiovascular Health, which has published its cardiovascular health plan for Europe, highlighting the need for secondary prevention policies through timely screening, early detection, and precise diagnosis. At a national level, the Belgian Alliance for Cardiovascular Health, for example, was formed in 2023 as a multi-stakeholder CVD alliance, focusing on engaging key stakeholders in CVD prevention nationally. So these presentations and our panel discussion subsequent will look at the different policies that can improve secondary prevention of CVD and what key considerations need to be taken into account to maximize impact and reduce the burden of CVD. And I'm very excited to now move forward. I'd like to first, before I introduce our speakers, thank our sponsors for today, who are Amgen and Novo Nordisk. We're very grateful for their support in delivering this important webinar. So our first speaker for today is Professor Clara Chow from the University of Sydney, Australia. Clara is a world-recognized expert in academic and clinical preventive cardiology, and she will discuss the WHF Secondary Prevention Roadmap update in her presentation. Thank you.
Thank you very much, Bill, and thank you for the invitation to talk today, as well as give you sort of the early insight into the World Heart Federation Roadmap on Secondary Prevention 2023 update, which we're on the brink of releasing. So just to quickly contextualize the World Heart Federation roadmaps, there are a number of roadmaps already, and the first roadmap was in secondary prevention, and this is the one we're updating now. So I think we all know that people who have suffered a heart attack or stroke are also at the greatest risk of a repeat cardiovascular event. There is strong evidence for the effectiveness and cost effectiveness of secondary prevention, but unfortunately uptake and adherence to secondary prevention is low globally. An example of this from recent research is the InterAspire study, which was presented at the European Society of Cardiology this year and showed that out of 4,500 patients across 14 countries, less than half were taking the 4 pillar drugs of secondary prevention, and only 1% were reaching all recommended risk factor and lifestyle targets. So the main goals of the update for the World Heart Federation Roadmap for Secondary Prevention of Cardiovascular Disease was to drive policy change, incorporate the substantial new literature and guidelines since 2015, identify the roadblocks to secondary prevention care, describe new and existing strategies for secondary cardiovascular disease prevention, particularly picking up on signal pill combinations and advances in digital health, and provide healthcare professionals and policymakers with some practical tools to consider in the different contexts they live and work. So this is just a summary of the recommended secondary prevention treatments, and the 4 pillars are really antiplatelets, lipid lowering, and ACE inhibitors and beta blockers, which I suppose broadly fall into blood pressure lowering. Cardiac rehab is obviously an important component of secondary prevention, as is lifestyle risk factor modification. But the other thing that the guidelines does touch on are other medical treatments, of which the evidence is growing on things like anti-inflammatory treatments and vaccination. So as part of the process for updating the roadmap, a global survey was conducted of World Heart Federation member organizations, and 268 responses came from 60 countries. The survey broadly looked at socio-demographic questions, local availability, affordability, and acceptability of medications and lifestyle interventions, and perspectives on specific roadblocks and solutions. I don't have time to go through them all today, but I'll touch on a few things. With respect to roadblocks at individual healthcare and system level, these were the sort of common ones. One, non-adherence and non-participation, so non-adherence to medications and non-participation in prevention programs. Inequities in access to cardiovascular care and treatments. Clinical inertia, the concept that despite a risk factor or a measure not being at target, for example, blood pressure, that the medication or treatment is not up titrated to achieve those risk factor targets. At a more healthcare and system level, the lack of investment in primary care and limited local guidelines and the lack of supportive environments, as well as an important component to consider the structural biases that may exist. So just a few things from the World Heart Federation survey. This is looking at the availability, affordability, acceptability of lifestyle intervention programs. The green is always and blue is very often. You can see in terms of are available in my country, smoking cessation programs are only available in just over half. Physical activity, a good availability in over half. Healthy diet, similarly, and psychosocial management maybe only 40%, but it's certainly not everybody, and this is availability. Now the next question was, are they affordable to patients? And again, a pretty low proportion or half or so are affordable to patients, and psychosocial management was the lowest of all of those, and are well accepted by patients, and incredibly important to seeing whether people will do these things. They also reported that always and very often were relatively low across what health providers perceive their patients to think. Now this is looking at barriers at the healthcare level by setting, and there's a lack of healthcare providers to prescribe priority interventions, and if the light blue and orange are strongly agree and strongly agree. So look, in Africa, a very large group thought there was a lack of healthcare providers to prescribe priority interventions, and across all regions except perhaps WHO European region, it was reported that there was a lack of healthcare prescribers to prescribe priority interventions. And the next question here is healthcare providers are not aware of guidelines. And again, similar sort of colouring, agree is light blue and orange is strongly agree. You can see up to half of people are not aware of guidelines in some of these regions. This one is looking at the excise tax for unhealthy foods and drinks. Green is yes. And for sugar sweetened beverages, you can see that there's a starting proportion of areas where there is sugar sweetened beverage taxes. And the second one is other unhealthy commodity taxes. So look, starting to see some changes in the context or the environment around people that is supporting healthy living. There's certainly a long way to go. All right, the next sort of section I'm just touching on are enablers or interventions at the individual healthcare provider and system level. And in terms of the individual level, the ones that were highlighted with health literacy interventions and interventions that supported self-management. And in terms of at the healthcare and system level enablers were post-ACS services, health professional support and training, access to cardiovascular disease prevention medications, national policies enabling fiscal policies, health setting environments to support health behaviours, and primary care structured monitoring and prescribing interventions in primary care. So these are sort of to give a framework or some tools for people to consider the sort of interventions that might work here. So the two areas that were highlighted as particular strategies and on which the evidence has changed substantially is fixed dose combination therapy. Fixed dose combination therapy, I think also commonly known as polypill, are available in a number of regions and can simplify a patient's therapeutic scheme by reducing the number of tablets needed per day, thereby promoting medical adherence. And this approach has been successful in hypertension and in the last few years has been shown successful in secondary prevention to improve clinical outcomes. So just, a concept note to remember the full fixed dose combination therapy is an important strategy. The other area that has also changed quite a bit in the last 8 years is digital health strategies to improve secondary prevention. A number of these have been developed and they focus on different things. For example, digital health interventions to improve risk factor management, help assist people get to risk factor target, digital health for cardiac rehab, and then specific digital health approaches are text messaging, wearables, and conversational AI, with the triple, I suppose, asterisks indicating the largest amount of evidence is in the text messaging area for digital health interventions, and there's less in looking at wearables and conversational AI. And digital health interventions to support health providers in decision making is another area where there's substantial evidence. Okay, so what's next? Well, the road update is about to be published, and hopefully after this we'll continue to raise, I suppose, discussions about this. Communications toolkit will be disseminated, and the World Heart Federation will be working to set up road roundtables in your various countries. So thank you.
Thank you, Professor Chow, and that was a very interesting update on the WHF Roadmap for Secondary Prevention, which we're excited to see come out shortly, and also for us to start at the global level. And now we'll move to a national initiative, which will be presented by Professor Rick Willems from the University of Leuven. Professor Willems is an academic cardiologist and has a focus on non-invasive cardiology and heart rhythm disease. And he'll be presenting on setting the stage for political awareness of secondary prevention, the experience of the Belgium Alliance of Cardiovascular Health, or BACH.
Thank you, Bill, for the nice introduction. I'm happy to present here our initiative, our Belgian Alliance on Cardiovascular Health. I feel a little bit off topic, but I think that just making or creating awareness on prevention is an important topic. So that's why I'm happy to present it here. So what we did is we started an alliance with a great number of players in the medical field. On the one hand, the patient organization, on the other hand, different scientific organizations within the field of not only cardiology, but also angiology and should have mentioned here the Stroke Council, so neurology, and then some industry partners with interest in cardiovascular health. And we started recently, so we are only setting baby steps, but we think we can maybe be an example for the international community to help us to get more attention for cardiovascular health. So what we did, and I don't have to convince you about the importance of cardiovascular health, but we were mainly focused on setting the stage on which message do we want to give to our policymakers. And of course, as in many countries, heart disease is still the largest cause of death and even beats cancer still. And that we have some health problems with the aging and obesity that will increase this problem in the near future. And we are very happy that we could make a very broad alliance, and that's where I touch upon our challenges that we have or we had in the alliance to get together and prepare the future. So we took this opportunity because it's as of the beginning of 2024, Belgium will be the president of the European Union for 6 months, and we also have national elections next year where we hope that we can make, at least for cardiovascular health, some priorities in health policies of the different political parties in our country. So we want our policymakers to get together and really make a cardiovascular plan, a little bit as an example for the Beating Cancer plan that the EU had in previous years. And we also want to stress the importance of data collection and research in that plan. So what were our key challenges when we set up our alliance? The key challenges that we are faced with internally are the balance between the involved medical partners. So although the Belgian Heart League is involved, it's still a challenge to really involve patients per se in the messages, but also in the context with policymakers. We still have to figure out how we can involve our general practitioners because they have a very important role in our healthcare system, certainly for both primary but also for secondary prevention. So there the challenge is the scientific organizations of GPs are a little bit more scattered, and so to find a good partner for the GPs is to talk to is one of the challenges we still face. Then one topic that I already nicely illustrated myself is that it's important in our broad alliance to keep a balance between the cardiologists who are big group versus the other involved specialists like the vascular surgeons or the neurologists who take care of patients of stroke. And there we had several times to go towards a messaging that is more broad than just focusing on cardiology itself, and to make it really a cardiovascular problem with also emphasis that it's not only the heart we're dealing with. Second internal challenge is the working together with industry. It's new for a lot of the involved scientific partners, where we need the financial support to set up actions, but we need to be scientifically independent in our statements. And a challenge within industry still is like how we will evolve with other interested partners like the medtech industry to set that up for the future. If we look at external challenges we're faced with, is that maybe not on a national level, but certainly on a European level, sometimes we're confronted with a plethora of lobbying groups. We get invitations, and also policymakers get invitations by different angles. So we need to work together to see that we all ask for the same thing. Typically for Belgium is that we have a difficult political structure where the country is divided in regions, and those regions have their own businesses, or so the region, the prevention is actually taken care by the regions of Flanders and Wallonia and Brussels, while cure is taken care by the Belgian government. So it's difficult to find out which partners to talk to. And then our latest challenge, that currently on a political level, there is a good focus on healthy living, for actions on healthy living, but they want to be less disease specific. Maybe that's a lesson they learned from the Beating Cancer Plan. So I think that could be either a curse or a blessing, because of course, cardiovascular healthy living is actually good for a lot of diseases, including cancer. Those are actually the same basic principles on healthy living. So what are we setting up practically now? We'll have actually our first official launch in 2 weeks, where we'll have a launch of our alliance at the Belgian Parliament, and they are all invited to that launch. So that'll be on the 9th of November. And we also have recently got an invitation by the Minister of Health to possibly organize a study day on cardiovascular prevention under the auspices of the Belgian presidency. And we hope that we can organize that, and that we can get support maybe from the involved partners here if we are able to organize this. So we're only setting baby steps in our organization. I'm happy to share it already on such an international platform as today. We hope that we can be an example for other nationalities to set up their group to strive to more political attention for this important topic. Thank you.
Thank you very much, Professor Willems. That was an outstanding presentation, and congratulations on all the work you're doing at the national level. I think you are an inspiration. I hope you will be for others at their national levels to look at forming similar alliances. We all get frustrated as clinical cardiologists when we are unable to prescribe patients in need with evidence-based therapies. For example, more recent lipid-lowering therapies, and so on and so forth. And I think one of the things that we're all recognizing now is the need for physicians to also think about influencing policymakers and advocating for patients, especially in the constrained healthcare environments that we operate in, particularly with respect to the budgets of healthcare systems nationally. So thank you for that, and we hope that you'll be an inspiration for other groups at the national level. So moving from the national level back to a regional level, it's now my pleasure to introduce Ms. Birgit Bejer from the European Heart Network. Birgit is the CEO of the European Heart Network, has a long history in policy and advocacy, particularly around public policy and healthcare policy. And she'll share with us some of the recent developments from the European Heart Network, and her talk is entitled Seizing the Moment, Efforts to Achieve Regional and National Policies for Secondary Prevention in the EU. Thank you.
Thank you very much, and hello everybody. Very pleased to be here with you at the webinar to discuss what can be done at regional level and where we can learn from each other towards the local and towards the global level to improve cardiovascular health for everyone. So the European Heart Network is a Brussels-based alliance of foundation and associations dedicated to fighting heart disease and stroke and representing patients' interests throughout Europe. So our member from Belgium is the Belgian Heart League, my predecessor has just mentioned. Our vision is that every European has a right to a life free from avoidable cardiovascular diseases. As a European region, we are looking what can we do. We see also what is found globally, that there's a big discrepancy, and we have that also in the region, that there's a big discrepancy between countries. So we have if cardiovascular health was a country, the capital would be heart disease and stroke. The economy, it costs a lot. The economic burden of cardiovascular disease is 210 billion in the region, and this does not only include the healthcare costs, but also costs for the loss of working life and let's say the cost of care, social care. The population is 63 million, almost the country of France. Mortality 1.8 million per year. And that is what I touched upon, just the productivity, that we lose 26 million a year to ill health and early death. And the population is growing. So 6 million per year, roughly the population of Denmark. That is the burden we are facing. And it is now, I think, COVID has taught us so well, unfortunately, that CVD is a group, CVD patients are a group which is touched most heavily, and we see if a health care system collapses, what it means for cardiovascular health, the backlog, etc. So we have created a certain awareness of policymakers that health is not only important, but cardiovascular health, how much it weighs and how heavy it is, and how important it is to reduce premature and preventable deaths, tackle inequalities, pave the way to better quality of life and the way for healthier lives for all, and create resilient healthcare systems. So the idea is to have a cardiovascular health plan, and from an EHN perspective, which is very close to a similar alliance which Professor Willem has just described, the Belgium Alliance. We have a European Alliance of Cardiovascular Health, so the EHN plan is very close to it. We focus ourselves 4 pillars: primary and secondary prevention, digital technologies as a way for saving lives and creating innovation, and also using this digital technology to modernize the cardiovascular patient's pathway, so that we have from primary until quaternary prevention, we have a seamless pathway. And overall, we want to achieve it, that to tackle inequalities. And with digital means, we hope to bridge also this way, if we tackle the health literacy and digital literacy, and of course the interoperability and this software and this. But there is a lot of work to do. So what is the role of secondary prevention in our plan? We want to see that unmodifiable risk factors such as genetic predisposition, congenital factors, functional decline due to aging, or cardiovascular morbidity due to other chronic conditions or infectious diseases such as COVID-19, and their therapies cannot be ignored. So this is very important. While we see that primary prevention has to go together with secondary prevention in order to improve the outcomes of secondary prevention, but we can't do prevent everything through primary prevention. We need secondary prevention, and this means we need reliable data on CVD that must be available. And if we have better data on CVD, we can stimulate also research and data-driven healthcare. So and in order to do a proper secondary prevention, of course, we need early detection. And that means, from our point of view, we have a study for that. We looked into it and worked also with the WHO on it. We needed targeted high-quality risk assessment programs that may help identify people at risk and determine the most appropriate preventive measures. In deprived communities, the rate of high-risk individuals is known to be significantly higher than in other areas. It is therefore critical to develop approaches that enable the inclusion of hard-to-reach groups. So that is a decisive policy demand, and for that we would like to establish a joint action or a network of member states supported by experts to identify the most effective policies and measures for reaching out to and managing individuals at high risk of developing CVD. Then another aspect of secondary prevention, we need improving treatment. That means substantial differences exist between countries in terms of access to technologies and procedures for treating patients with cardiovascular disease. If you compare Bulgaria to Germany, you'd see horrific differences because the healthcare systems are completely different, under resourced, but also in a structural way designed. So a lot of the population just does not have access to basic measures. And while access to innovative treatment correlates with health expenditure per capita in a country, budget allocation explains only some of the variation in provision. So there's a multifactorial consideration to be taken. We recommend that the EU must ensure adequate capacity for full operational regulatory health systems concerning pharmaceuticals and medical devices alike. There's the need to cooperate in the health technology assessment at EU level. Is equally important for reducing inequalities in CVD treatment and wasteful spending, allowing decision makers to take informed decisions based on the clinical effectiveness of technologies. In this respect, patients and healthcare professionals must be involved. So that is from a patient organization a very important demand, that patients are included in co-creating this healthcare system, ensuring that whatever is developed or reimbursed or funded will contribute to the quality of life, is indeed a meaningful health outcome from a patient perspective. And that means early inclusion in research, in formulating research questions, in evaluating the product, and overseeing also the once the product is on the market, the evaluation afterwards, so that we overall have a safe, effective, and equitable system. Then we also look at cardiac and stroke rehabilitation and secondary prevention as a crucial part of treatment for CVD is rehabilitation after an event, including counseling, medical treatment, exercise, and psychological support. These programs help prevent recurrence, improve functional capacity, recovery, and psychological well-being. They help patients regain as normal life as possible, optimize their quality of life, and reduce the burden on health systems by reducing hospital readmissions. And I think there are studies out in health economics which underline the importance of that rehabilitation process. So also here we need from a political level at EU level and part of a cardiovascular health plan, European definition of cardiac and stroke rehabilitation. And again, it is this cooperation we need between member states. One member state cannot do it alone. It is impossible. So we need a network of member states at the regional level to identify barriers for uptake of cardiac and stroke rehabilitation and secondary prevention programs and how to address them. Yeah, this is in a nutshell what I wanted to say, and I find it very encouraging that member states are coming forward with national cardiovascular health plans. We see are looking to Spain, who have as the latest and newest one, quite complex one, but also apparently Poland and Hungary are on their way to it. And I think this is a kind of movement we have to encourage, and we try to do this in order with the Alliance of Cardiovascular Health to mobilize policymakers in the next mandate of the European Union. So we are electing a European Parliament, but then also a new European Commission to take this impulse from the national level to have it at European level, and thus promote cardiovascular health for all through national health plans, but which are also anchored at a European level and have thus a stimulating top-down, bottom-up, top-down, and vice versa effect. So I look very much forward to working with everybody on this topic.
Thank you very much, Birgit. And we'll now move on with the next agenda item, which is panel discussion. I'd like to thank all our speakers for giving their presentations on time. So we have plenty of time for discussion. And I'd encourage those who are connected to the webinar or on YouTube stream to submit questions that we can hopefully try to respond to. I'll get things started with a question for Professor Chow. And just wanted to ask you that the update on the WHO roadmap is from the first edition, which was published in 2015. What would you say are the major advances in secondary prevention over the last 8 years to inform this new update?
Thanks, Bill. Obviously, there's been a lot of research in secondary prevention, but I think if I pick a few top line things, is the evidence around the new strategies, particularly the fixed dose combination therapy, and the evidence around the potential of digital health interventions is probably what has changed most in the last 8 years. Look, we've had some new therapies that have been investigated, and some of them are starting to make their way to guidelines. But I think the sort of medical treatments, lifestyle modification, cardiac rehab, that is all what we knew, but what we didn't know, I suppose, was how to better implement secondary prevention. And I think that's where the evidence and research has probably tried to meet that gap over the last 8 years.
Very good. Thank you. I think we've probably, from my perspective, also moved towards maybe more intensive control of the main risk factors like blood pressure and dyslipidemia. If anything, that creates additional challenge, because we know with the prior more relaxed targets, if you will, that there was even difficulty achieving those. But still, we have to follow the evidence, and we know that lower is better for LDL cholesterol and for blood pressure in general. And so it's a real challenge for us to try to address, and we hope that the roadmap will allow us to do so. Can I ask Professor Chow, how would one access the roadmap and interact with it, use it when it's available? Where will it be for access and so on, just from a practical point of view?
Thanks, Bill. And firstly, I agree with you on all of those important pieces of evidence about intensification of risk factor targets. And it will be published in Global Heart, and it will also be available through the World Heart Federation, as will a number of toolkits with respect to providing, I suppose, sort of summarized messages around the roadmap. The roadmap is still meant to be a reasonably short document with a lot of, I suppose, the evidence compiled in a very large reference list. So it is kind of all trying to be there in one spot, but equally trying to be accessible to a large range of people. It'll be also available in the form of simplified tools.
Very good. And do we have an approximate timeline? I know it's hard to predict these things with journals and peer review and publication backlogs and so forth, but when do we expect to be able to access the roadmap?
Look, I'm still hoping that it'll be before the end of the year. It's gone through a fair bit of the peer review already, actually. So, you know, I suppose the timing of the publication date is not 100% certain, but it has gone through peer review, and I suppose, you know, we all know, I suppose, roughly what that means.
Yeah. Okay. All right. Hopefully by the end of the year, and I'm sure when it does come out, there will be a lot of notifications and press releases and so forth from the World Heart Federation. So we'll look forward to that. Maybe if I could move on to Professor Willems. I just
can I interrupt? Because
yes.
There was one question here from the audience that I think may be interesting for Professor Shah and somebody, Dr. Ganesh Kumar from India asked what are the key pragmatic priorities we should put at the policy level in any nation to target secondary prevention of cardiovascular events. What do you think are the key pragmatic priorities, and do we have to make a difference in low income versus high income countries or something
Yeah, it is indeed a good question. I think what the roadmap is going to try to be is not 100% prescriptive, but provide a framework by which you could identify those priorities, and a framework by which you could identify what your main barriers are to secondary prevention in your country and what your main potential enablers or low-hanging fruit might be. I am sure that will be different in low income, middle income and higher income countries. You know, I am probably Dr. Ganesh Kumar from India would have a better idea of what might be potentially pragmatic, for example, in India, but you know, it might be things like addressing availability and affordability of secondary prevention medicines, maybe a little bit more important in low income countries comparatively to higher income countries. But equally, it might be, you know, considering healthcare providers and the relative lack of healthcare providers, and considering task shifting or other approaches to provide secondary prevention care. But I mean, I suppose I'm jumping to potential interventions, but I think that what the roadmap is going to try to do is put a framework for people to consider it. And then hopefully with the round tables that the World Heart Federation is very happy to facilitate in each of the countries, that could help, I suppose, identify what in their country might be pragmatic, but also priority for that country. But thanks for flagging that, Rick.
Great question, and thank you for that answer, Clara. I'll perhaps ask Rick a question, if that's okay. What did you find was the biggest barrier to creating your alliance at the national level? Was it looking for resources to put together a team or a project manager, or what kind of spark did you need to ignite that flame?
So the initiative in the scientific organizations was mainly driven by the feeling that we lacked priority in policy for cardiovascular diseases, and that was both on the topic of new therapies, but also on the topic of research funding. And therefore, in the scientific organizations, there was really the tendency to become more active on a policy level. So that was also sparked by mainly our patient organization, the Belgian Cardiac League, who also had that feeling and shared that feeling. So that was our main spark. And then if you look, what was the challenge was a little bit, lobbying and science, it's a different business. And that's still a little bit the challenge that we're faced to. Like every organization, we're fully practicing cardiologists, so taking on that task on top of a clinical task and some people research task and others also teaching task. It's you have to find your way, and it's so that's the first difficulty, and then the transparency of the political decision making is an ongoing challenge. I think those are the main challenges.
Thank you, Rick. And I could sympathize with some of your experiences. Certainly in Ireland, we've had similar motivations to spark this interest in policy, particularly aligned to access for new preventive therapies, which are quite restricted, and also recognition that cardiovascular disease research and cardiovascular prevention research hasn't probably gotten the same interest from funders as other healthcare aspects, despite the fact that this is still a major cause, if not a leading cause of death in most countries. And so we've learned that unfortunately the chick in the nest who's chirping the loudest is the one who gets the most food, and so we need to try to raise all our voices as clinicians if we're to be able to provide the kind of therapies that we'd like to provide to our patients, and do the research that we think is important to further our understanding of CVD prevention, so that we can improve care and outcomes for those that we look after. So maybe another question for Birgit. How important is the patient voice in today's policy environment?
More and more important, I think. It's there is a shift. At least I can say for the European level that it's always much more convincing is if doctors come with patients, because the policy makers they listen better. It is also let's say from the institutional side. So if you're doing Horizon research projects, you will get better funding. You will be better evaluated as a research proposal if you have an engaged patient group within your research study, which helps to co-create the research, helps with the research questions, and because I think that policymakers see the value of the improvement of quality of life. And if that is indeed the outcome of their policy endeavors, that they say they're not just doing policy for making policy, but actually they are creating policy which helps in the end, which makes a difference. And this is it's a way where they see it makes sense. Whatever is produced, we are sure it will help patients, and it will be the quality of life. And the same is, of course, to involve the healthcare professionals in order to be sure whatever is used is effective, is scientifically based, is recognized, and makes sense. So it is very, very important to have all players in the consideration, but patients are an important factor in order to ensure that whatever is created is in the end useful and improves the quality of life of people.
Thank you for that response. That's great insight from your perspective. I agree. I think you would think that advocating or arguing for CVD preventive initiatives at the national level, regional level, maybe even international level would be easy because many of them are cost effective. In some cases, even cost savings can be found from
Yeah.
CVD prevention initiatives. But unfortunately, in today's constrained budgetary environment, the healthcare level, many of the resources are going to be given to areas where there's a sense that there's a strong public demand for these types of resources like cancer care, etc. Um, and so I think we need to not only make the case on financial grounds, and I think in that instance we have a very strong case for CVD
Yeah.
prevention, but also make the case that there's a public demand for this, and that in the absence of allocating financial resources to CVD prevention, there will be public consequences, and maybe that's something that is most clear to our policymakers, and the patient voice there is so important in that regard.
Indeed.
So we have a few questions from the audience, and maybe I'll ask Clara one question if that's okay. And I know that you conducted a survey that you presented some of your data on with respect to this WHF roadmap. But one question that came in is, how do we determine barriers in the CVD prevention roadmap and other roadmaps, online surveys, or what kind of advice do you have for national stakeholders like clinicians or CVD prevention leaders in identifying barriers at the national level to implementing some of these initiatives?
Thanks, Bill. I suppose for the actual roadmap, I mean, we use two processes. One was just literature review and collating, the literature as well as perspectives. We had an international steering committee in terms of identifying barriers and enablers, and then on top of that, we did a survey of WHO member countries, and got their perspectives. But in a country, if you were trying to determine barriers to cardiovascular prevention within your country, there are a range of different approaches. Perhaps something that might be simpler than well, multi-methods is always a good approach to identifying barriers, but something that could be a relatively good way to start is bringing the stakeholders in the room with respect to providing cardiovascular disease secondary prevention. That includes the patients, the consumers, the health providers, both primary and quaternary and tertiary level care, the policy makers, and the health service, I suppose, delivery sort of groupings, as well as other organisations that might be involved in secondary prevention, bringing them into a room and running focus group discussions to identify barriers and enablers in their region or country. This might be one approach. Again, I think the World Heart Federation might facilitate some of these things, but I suppose the question is time and resource. But I don't think just simple online surveys is the best way to identify barriers, because that often presumes that we know what the barriers are. And an online survey is easier to sort of answer yes or no, and it's harder to sort of draw out from groups what really they think are the potential barriers to implementing secondary prevention, which is why I'm sort of advocating at least a multi-methods or a qualitative approach.
Very good. Thank you for that, Clara. I think one thing that also comes to mind is our InterAspire study that we presented at the ESC meeting this summer, and I was lucky to be co-PI of that study with Professor David Wood. I guess we've talked about low-hanging fruit, and we certainly identified for secondary prevention, and remember, this is 1/3 of the overall burden of CVD, that at the global level, the access to cardiac rehabilitation is quite poor. only about 9% of the participants had attended more than half the recommended cardiovascular or cardiac rehab sessions. And I think that's one thing that certainly we took away from analyzing our data, and we're preparing the publication as we speak, that perhaps at the national level and regionally and even internationally, really a strong advocacy for cardiac rehabilitation might be one way to improve implementation of CVD prevention in these secondary prevention patients. So something just for the audience to think about, to make sure that if you are pursuing these policy approaches, if you are creating alliances, if you have the desire to try to improve things and advocate for our patients, to involve the cardiac rehab community, because I think that there's a big need in that space. So maybe one final question, and I'll try to think about who's the best person to ask. I feel like I've asked Clara many questions, so we'll maybe ask Rick if you have any ideas on how we can increase awareness and improve the education of the public. Obviously, in Belgium, you're in a high income community, but also in lower income communities. What kind of things do you think can help in terms of educating and creating awareness amongst the public on CVD prevention?
Yeah, I think that it's really a big difference in where you're at. Of course, if your basic need is just to get food, then it will be different to get to healthy food. Even so, in my opinion, if I look at my own our national challenges, I think that reaching the people that don't go to rehabilitation, because it's usually a social difference. It's actually the ones that are highly educated and have a high income, they attend the cardiac rehabilitation, but it's the low income, lesser educated that don't attend. And so that's how to deal with those. Therefore, affordability is very important, and really getting health coaches to a level that it's affordable, and maybe to the communities there would be probably a better choice. And then I think just another way, but it's already said by Clara, is the primary care physicians, and help them in their digital health platforms to screen and monitor the goals of secondary prevention, and to really build together with GPs and the companies that make the software to build algorithms to alarm us when those are not reached, and those can be, that I would say for Belgian point of view, would be priorities. On a global level, I really have to admit that you better ask Clara or somebody with more expertise, I think.
Yeah, I think the point is fair, that not everybody maybe have the same access to digital content, but I think at the same time, one universal truth of modern society is, even in low middle income countries, access to smartphones and so there are avenues to access patients and create better awareness and education around CVD, and remind folks that this is a problem that hasn't been solved. I think there's a perception out there that CVD is something that we've figured out, and that we need to move on and cure cancer or something, and we don't necessarily maybe recognize, or at least the public may not recognize, that CVD remains just as significant a contributor to mortality and morbidity as cancer does, and we haven't figured it out. We haven't a cure for CVD. So I think we've only got a minute left, so maybe I'll just close the webinar now. I'd like to again thank our sponsors for supporting this very, very important webinar, and the sponsors were Amgen and Novo Nordisk. And maybe finish by saying that we need to have perhaps a lower level of tolerance or acceptability for recurrent cardiovascular disease in our patients and in our public. In patients who are diagnosed with cancer, everything is done to provide access to evidence-based treatments. And governments that don't provide that access hear about it from the public. And I think something similar in cardiovascular disease needs to happen. We need to not have this perhaps inertia or ambivalence towards recurrent cardiovascular disease. They can be prevented. We have access to treatments, and we need to shout loud and make it less acceptable for these recurrent events to happen. And I hope that following this webinar, you'll come away with that motivation and that mindset, because it's a really important mindset, and we could prevent a lot of recurrent disease and death by not having that acceptance of the fact that CVD prevention or recurrence is something that will happen and we can't do anything about it. We can. So I'll finish there. Thank you.